So we have the first question, please. So Swaminathan, we all know, he's a cytokine man, a pure scientist, and Gatinel believes in whatever he does. So this slide is something we start off with. This is, I think, yesterday you put this slide somewhere. Can you put the other one also? Can you click it on? So if you read the first one, we just took it from your own slides. In the question of science, the authority of 1,000 is not worth the humble reasoning of a single individual. This is what Galilei said. So we want to know eye rubbing. We all know eye rubbing does happen, but all eye rubbers don't get the disease. Thus, your theory is good enough for reasoning for the masses. Just a quick 1 minute on this.
So, you want me to comment on this?
I know you don't want to comment on the first one, but the second one is, I want you to comment.
Well, what I'm just here to is just to expose the reasons why I believe that eye rubbing is probably not the whole thing, but the point which is important is that I think, and there are many evidences, even in this conference, showing that because of the nature of keratoconus, which is focal, and because of the epidemiology of it, and I've seen slides where in a pediatric situation, more than 80% of the children acknowledge, or their parents, eye rubbing, that eye rubbing is the necessary ingredient in the keratoconus recipe. But, of course, every eye rubber does not get to develop a keratoconus, fortunately, because we all do. And I have a picture of me on a podium in a congress in Greece. Lately, I was rubbing my eyes like this, you know, and they put it on Facebook.
It's coming up.
So
we got that photograph.
Yeah. Okay. I'm cutting grass. So that's my point. And again, I think, right.
So I
yes,
just want you to hold here, but I know that we've seen this, and we also seen this pathways. Where do you think he's wrong?
I think it's incomplete. It's incomplete on two fronts.
This is a healthy discussion, Gatinel. So Swami is a great debater. So
I was going through your literature just to make sure that I believe as much as you do. The noise in the literature was weak. It was not even strong, because there are close to 10 articles which talks about eye rubbing in keratoconus, and it says close to 50% of the eye rubbing of the keratoconus patients were eye rubbing. The other 50%, we do not know what's happening. And one of the most important lacuna in most of the study is we have not done a general population study where say how many of the normal people have eye rubbing in the process. So
to put it in simpler English, you mean that everybody who rubs the eyes is not getting keratoconus.
Yes.
So that's it. That's what he's trying to say.
That everyone who rubs eye doesn't get to a keratoconus, of course.
Or not, even those eye rubbers who look like keratoconus don't get keratoconus.
No, let me give you a clear analogy which I published lately. Because people ask me this question, why do not every eye rubber develop keratoconus? It's like, to me, as if you were saying that as soon as you go to the beach, you get a sunburn. No. But if you have a light skin, if you stay longer, if you go at midday, if you don't put oil on your skin, the chances are you're going to develop a sunburn. To develop a sunburn, you need one ingredient, UV light. I mean, to be exposed to some level of UV light. UV light is to sunburn the vulnerant agent. What eye rubbing is to keratoconus, in my opinion, that's my opinion, and I can explain why. Second point, which is important, I think there's a complete misunderstanding of the keratoconus physiology, because, and I take this often as an example, as a paradox, which is not a paradox to me, is that the Marfan syndrome, which is by definition a mutation of the collagen, which is identified on the fibrillin, as you know, TGF-beta1 gene, which causes a full body keratoconus. You have an ectasia of the aorta. The aorta is an organ which is exposed to a lot of pressure, you know, as soon as the heart is pumping blood out of the ventricle. So it develops an ectasia there. You can have a spine which is having scoliosis, and yet at the cornea level, those patients, they do not develop keratoconus, they develop the opposite trend. That is, of course, the cornea thins because it stretches, but it gets flatter, which is not a surprise because the eye is exposed to a homogeneous intraocular pressure difference with atmospheric pressure, which makes the cornea progressively distending. Whereas in keratoconus, what you see on all this presentation, it's focal, it's sometimes even unilateral in one eye, not the other one. It's in the center of the cornea, and if you do Brewer microscopy, it's sparing the periphery of the cornea. I mean,
I need to ask you a simple question.
yeah.
Which came first? The eye rubbers became keratoconic or rubbing became keratoconic?
It's simple.
It's
Ask
a
your
chicken and
patient.
egg.
All my patients, all of them, it's my patients, and we have a website where we put them these cases. They always say the same story. I started to rub my eye, and about 2-3 years later, I developed a keratoconus. So in all patients, eye rubbing precedes keratoconus.
Exactly. Do you
So-
agree, Swami?
I
Yeah.
think he's very good at driving the point that eye rubbing is associated with
So which
keratoconus.
comes first, chicken or egg? You like chicken,
I
know
think it
that.
just coexists.
Rohit,
I
one
just
second.
think it's
Whichever
coexist.
you order first comes first.
Sorry?
If you order the chicken, it will come first. If you order the egg, it will come second. Whichever you order in the menu, it comes first.
Oh, that's true. I think this is parallel order. So the keratoconus and eye rubbing is
We
a
needed
class-
you for this. Dr. Anand Bandari is the professor, head of the department of MS Ramaya. He's a great guy and great orator and everything.
One more question. I don't know to ask Swami or Gati.
Doesn't matter.
This eye rubbing, if it is so, then most of our homemakers, when they see Hindi serials, should also get keratoconus. They keep crying and rubbing their eyes up, and so why not in them? Why not? Why only children who are not seeing Hindi serials?
We'll ask Soumya this question. How many of you've been seeing a lot of
I don't understand what
children with allergy who have itching, who have problems? So you also see a lot of children
they
with
cry.
keratoconus lately. Do you think which one is the first? Forget what Anand just said. Is this what triggers something in the immunology of the body triggers them, or it's just a local condition? As an immunologist, can you have a local condition itself?
Yes, I agree.
You need to bring it closer so that you can hear.
I agree with Dr. Swami that it is an association with keratoconus in an allergic eye disease, because when eye rubbing is there, it triggers off local inflammatory response, and then it releases local inflammatory cascade which may lead on to an allergic eye disease. Probably I feel it may be an association with keratoconus.
So one of the things I do in my practice is, I don't know whether you follow it, I do an eosinophil count and an IgE as one of my first things in a patient who is complains of eye rubbing or less than 18 years. And I think you've seen that at least those who are strong eye rubbers, at least 85% of them have a very high IgE. One of the things which I want to ask you, I mean, this is more like, it's not just a debate, it's also like a small thing about eye rubbing. So one of the things I wanted to ask you is, how significant, we are living in Bangalore, and Bangalore has pollens, and many patients many of a normal IgE level is more than 150, 200. As an immunologist or a physician, what level of IgE should we be bothered about? Or is there anything else other than IgE which we should consider?
IgE just gives us atopic status of the patient. Yes, higher IgE levels are associated with specific allergies, but I would be more interested in knowing what is the specific allergy to the aeroallergens. In my practice, the most sensitization I see is to dust mites. Next comes pollens, which are very relevant in Bangalore practice, and pet dander, followed by aspergillus sensitization, especially in adolescents and adults.
So basically what we do in our practice in patients with allergy is, many times we tell them that there is an allergy, we keep giving them steroids, lubricant, it doesn't get better. because there is a local and a systemic problem together in the same patient. So we do an IgE. If it's high, refer it to an immunologist. And if I remember your practice, she would look at what the patient is sensitized for. And the most common sensitized factor in these patients are starting from house mites, cockroaches, sometimes dust, sometimes cotton, wool. We have a lot of them. And what do you do once you get this thing in the child? What do you do next from an immunologist's point of view? Say that the patient is sensitized to cotton. So what do you do?
I revisit the history. Again,
Can you just bring it closer, please?
a positives testing, allergy testing does not mean they are allergic. Again, you have to go back to the history, and I give them appropriate avoidance measures. And this probably helps in majority of the patients to decrease the symptoms and the need for medicines. If not, the next thing is something called allergen immunotherapy, which induces tolerance to what they are allergic to and helps improve their quality of life in the long run.
Basically, what I remember is called SLIT, right?
Sublingual immunotherapy.
Sublingual immunotherapy. Sublingual immunotherapy is you sensitize the person to that particular allergen.
We desensitize the patient.
Desensitize. One of the challenges I face with this, I see we co-manage a lot of this bad keratoconus with bad allergies, and they symptomatically they get better, but the IgE, which is say 4,000, doesn't come to 400. It still remains high. Is it because the patients are always concerned because they stop the treatment saying this is very important. This point is important because one of the major causes of failure of any of this immunological therapies is the numbers, and we are all interested in mathematical numbers because like how blood pressure is, it has to come down. But when you give this treatment, the child stops rubbing, the allergy stops, but the IgE on the paper doesn't come down. What do we do with this?
I always go back on the symptom score, the need for use for medication, and how the quality of life has improved. The IgE will not come down immediately. Probably the time taken for the IgE to come down is from 6 to 12 months after the initiation of therapy. So there is no use repeating IgE 1 or 2 months after the initiation of therapy. So I wouldn't go by the numbers. I always go by the symptom score and the combination of the quality of life. Unfortunately, right now the novelty biomarkers for the progression of immunotherapy is still in research and not into clinical practice yet, but probably in 1 or 2 years we may have such biomarkers for clinical practice.
So basically, we've been managing for quite some time now, and trust me, it's doing wonderfully well. I'm not saying that we are able to treat keratoconus, I'm not saying that we are able to treat progression, but what is happening is the comfort level and zone of how a patient feels is much better. So if I get a child and he's an eye rubber and he has a lot of these signs, I wait for close to 6 months before she gives me a clearance. It's like patient with diabetics. Would you take him up for a surgery? You would not. You would want him to get ready. So the allergy is exactly the same. You would not want to touch a patient who is already angry. Am I right? If you are immunologically angry, you will always get an angry response. An angry response can be infiltrates, non-wound healing, scarring, multiple points. So once you settle down, the patients actually are more comfortable. That's when you take it. So there's nothing called hurry in a pediatric cross-linking.
Much more.
Yes, sir.
Much more often than exogenous allergens, what we face is spring catarrh, which is common in these younger children, and that's one of the main reasons why they keep rubbing their eyes. What do you do in those cases? I mean, all these tests and the treatment relevant in these cases, spring catarrh, or you do something different?
You're talking about
It's a spring catarrh is a type of allergy. It's seasonal allergy where the child has.
It's got nothing to do with exogenous agents.
Yes, sir. Probably we do have an skin prick test where we could demonstrate IgE sensitization to such thing, and there are some certain case reports where allergen immunotherapy has worked in this allergy.
It looks localized, but there could be a systemic component associated with this, is what she's trying to say. For example, if they're allergic to dust mites, it can be, dust mites can be in anywhere in your system. Or if you have a pet, the pet can have issues. So that is what she's trying to say.
Dust mites is critical because we have noticed a striking correlation between the way people sleep, especially when they sleep on the stomach or on the side, and the eye, which is the more severe. And in many unilateral cases, which are really strictly unilateral, we have like 7% of them. What we found was that the patient usually sleeps always on the same side and rubs only one eye, and when they rub their eye, they may contaminate the ocular surface with allergens. So it's like creating a vicious circle, and you need to break that. But many parents are like doing allergy treatment for their children, but they forget to change the linen and choose dust mite resistance, linen, and that's critical to first get that linen for allergic people, and second, explain that the child should sleep on the back, or I give them shields at night to sleep. And what is striking also is that when you do this, it's just a test sometimes, because people would say, I'm not sure, I'm rubbing my eyes, maybe at night. Okay, wear a patch at night, and in the morning, what they observe is that the patch has gone, and usually has gone on the eye which is more severe, and the eye which is the most severe is the eye which is probably rubbed at night or compressed or everything, which is mechanically triggering further deformation.
We co-managed one case of exactly same thing like you said. The child had unilateral KC which was progressing very, very rapidly. One eye has curvature of 65, other one had say 42 or something. And the child had allergic to, if you remember right, two important things. The child was allergic to cotton, and the child was allergic to dust mites.
Yeah.
And when we asked the child, it's not just allergy, the child was allergic to these two, and the child was sleeping on one side, and your bed linens are cotton, and they had maybe dust mites on them. And the child got sensitized to all this. It did not stop, but the symptoms became much better.
Yeah,
and
but
hopefully we can probably prevent from the other eye. The question I wanted to ask you at this point of time is, if you ask the child to sleep on the other eye, other side, like you rightly said, it was a very great point. He said, when you see a unilateral KC, that means there is something in that side which is bothering the child. And you say, okay, don't sleep on other side, sleep on the other side. If the allergy is there, the child will get it on the other side also very quickly. So what you rightly said is you sleep straight, but it's very difficult for somebody who does not. Sleeping is a pattern of mind.
But it's not only allergy as well. There's like cases published on punctal agenesis, like no punctal plug, so non-punctal holes, So this agenesis created eye rubbing, and the child developed keratoconus. Leber congenital amaurosis children also rub their eye to stimulate the retina and the visual sensation, and it's also explaining the keratoconus incidence in this population. And so there are many case reports in the literature showing that someone who didn't have anything start for some reason to rub his or both eyes and developed keratoconus. I have a patient, he's 40, he developed keratoconus by the age of 38 because he met a girl who was living in the Burgundy area in France, and so he moved there and he was not exposed to all the pollens there, the new pollens he was exposed to. He developed allergy by the age of 35, and the first sign of keratoconus occurred like 2 years later. And we have many, many stories like that.
The other question I want to ask directly to you is a year or 2 years back, when I started working with the immunologist, you came a year back, I started a few years back. The one thing which was always asked to me is IgE or testing in these conditions is useless. That's the first thing. The second is immunotherapy and doing any of the patch or inhalation thing is outdated. I want an immunologist to answer, because when an ophthalmologist answers this, they think that I have a huge financial interest in this allergy testing. Because is this testing of allergy, we are the only specialty which do not get into all this testing, because we assume that everything is localized to the eye. If we see some papillae, we think it's the eye which is driving the papillae, not the body. I mean, as an immunologist, you answer this question and then we can sum up this discussion-based debate, the healthy debate actually.
There's definitely a role for testing of specific IgE in localized allergies as well, which applies to eye as well, because there is a component of allergy which is a factor which drives the immunopathology. So if we can identify the trigger and appropriately try to avoid it, definitely it does help the patient. In patients who are not controlled by avoidance and pharmacotherapy, allergen immunotherapy is one promising field which does help the patient in the long run by switching from Th2 response, which is allergic prone response, to Th1. And the world allergy bodies like YACI and American Academy of Allergy and Clinical Immunology have recognized the role of immunotherapy in allergic conjunctivitis as well as allergic rhinoconjunctivitis.
So testing somebody in an allergic condition, like a child who rubs badly, and doing a test of what he or she is allergic to is not an outdated, old-fashioned way of looking at it, right?
Definitely no.
So that's the most important take-home point here. So we should not, see, of course, there's not much of a literature that does not exist, it does not exist there. But if you, when she came in, she sent me a bunch of papers written by non-ophthalmologists on the same subject. But we as ophthalmologists has not adapted that, right? One of the big association has sent why we need these allergic tests. I've had a patient with dry eye who would never respond. Her IgE was very high and she was allergic to almonds. She came from Bombay and she used to eat almonds morning, afternoon, evening because it's healthy, and she started incorporating into her system recently. So it is not, almonds eating has got nothing to the eye dryness, but it is how the immunology is. And one of the most confusing branches in the human body is immunology, because it's extremely vague.
Rohit, what we do is we do allergy testing, but usually there are three main areas we find in children with allergy. One is the eye, the second is childhood asthma, and the third is atopic skin. Of course, allergic rhinitis goes with the eye most times. If there are at least two of these present, it's much easier to convince the parents of the child to allow for allergy testing and to allow for immunotherapy. We don't do it by sublingual route, we do immunotherapy by the intramuscular route. So we give the same way desensitizing doses. I've been doing it since over a decade. But usually I found that it's easier to convince the parents only if there is at least an asthma or a skin problem along with it.
But when they convince, it works better. So one of the things, before I sum up this discussion about today's and yesterday's, is we as ophthalmologists desperately need to work with people outside our own domain. Yesterday was, we had a small talk about psychiatry, today is immunology. There are a lot of places where there's so much of crosstalk, and unless you start talking, and I don't refer a case to her, nor she just treats the patient. We have to keep in touch on every single patient, because every day after she sees, she sends me the report, I see the report, and there are times when we co-manage it. So you'll have to first find somebody, and you will find somebody like that. It will be a psychiatrist, it will be an immunologist, and this is going to really change your patient care. The last point from Mukesh, and then we move on.
I just have a question, because this is a very relevant topic. How do you actually go about clinically testing allergy? In that sense, what I want to know is from you or Dr. Somya, how tedious is the process? Is it a simple procedure or it is a time-consuming process? You test each allergen, how do you go about it? And how do the child and the parents feel about it? And then how many times are you able to pinpoint allergen? Let's say you test 10 children.
I got it. Yeah. So basically my role, say in keratoconus, this is a keratoconus session, is to get a eosinophil count and a basic IgE level. If it's 100, 150, I don't even bother to send it to her. Normal is 0 to 150, depends on the age. But when it's 300 or 400, I know that the person is having allergic to something, and then it goes to her. Now the answer is from your end. How difficult, one question is how difficult is to convince the parents to go in for one of this allergic tests, and how complex it is and how much time it takes.
if the patient is suffering enough to the quality of life being affected, it just needs just spending few minutes addressing their concerns and just telling them that if we are able to identify what trigger is causing their pathology, they would be happy to be tested for it. And testing for an aeroallergen is not very tedious. We are looking at the specific IgE. It can be done either through allergy skin prick test or blood specific IgE. I personally prefer doing a skin prick test because multiple allergens could be tested in one go, and it takes about 15 minutes because we are looking for the local wheal and flare reaction, that is type 1 hypersensitivity reaction on the cutaneous mast cells. And by showing the patient the demonstration of that reaction to that particular allergen actually drives them to follow that specific allergen avoidance measures. So doing a skin prick test is far more easier, and it is very cost effective for the patient as well.
Are you always able to identify an allergen, or there is a success rate kind of a thing?
In about 95 to 97% of the patients, we could identify the allergen. Again, selecting which allergen to be tested is based on the patient's history, and in patients who are on antihistamines or there is ambiguity on the skin prick test, then we would go for the blood specific IgE.
Both of you can look into this slide, and we end it with this. It was a great discussion. Thank you, Dr. Soumya. We have to stop rubbing. We believe in you that dry rubbing is a problem. We also believe in you. There are many other reasons why people could rub. But at the end of it, we all know we have to stop rubbing. And how to stop rubbing is not by just telling them you stop rubbing. I don't think, can you ask somebody to just stop rubbing? Will they stop, Dr. Bandari? Exactly. So we have to go out of the box and take a little effort to find. Do you agree with this? Yes or no?
With this?
Just
or with?
Everything. We have to have a holistic way of stopping the eye rubbing.
No, I think, again, I believe that eye rubbing is the indispensable sine qua non agent for keratoconus, and logically, if you suppress it, you stabilize it, or even better, if you suppress it before keratoconus occurs, you may prevent keratoconus on this planet. That's the logical consequence of what I'm saying. So what we do, no, but seriously, what we do in the Rothschild Foundation, and it's a critical issue because I have secondary opinion weekly, that is parents coming with a 16-year-old child with a cross-linking prescription without sometimes any documentation of any progression. But anyway, they ask me, what is your opinion? And I say, you know, I do the investigation, interview, and we find this high rubbing story.
For you.
No, but let me finish. And then we have this cessation of eye rubbing. And guess what? And we have a website which is called defeatkeratoconus.com, where we openly share those cases. We document by different maps the non-progression of all patients who really strictly stop rubbing. The only one who progress, they usually admit that they still rub. I have a patient, he progresses one eye because he says, this eye is so damaged, my vision is so poor, and eye rubbing is so pleasurable that I'd rather rub this eye and get the other eye. So this eye is for the pleasure and this one is for eyesight.
So you believe the world should stop eye rubbing?
The goal is to stop eye rubbing.
Can you just turn around?
Yeah, exactly. That's
so
me.
The world should stop eye rubbing.
Yeah, but when I do it, I must tell you, because what is amazing is that when you do the real history with people who are really openly discussing with you, it's not like a little rub they do. They exert a pressure which is very strong. And there is a paper by McMonis where he has calculated that the pressure that heavy rubbers exert on the eye is about 1,000 millimeters of mercury, which is equivalent to 1 bar, which is equivalent to the pressure in your car tire. Because when they rub with the knuckles and with their fist, for a shell which is 0.5 millimeter,
so how much pressure does this give?
Yeah, but so when I rub, I do rub like everyone, but I'm not really like scratching my eyes like crazy. So what is important also for rubbers is that if they can't help stopping rubbing, you just explain to them that they can rub, but use the cheekbone to massage the eyelid, because usually it's not the eye which rubs basically, it's the eyelid margin. So I teach them to rub against the nose, against the eyelid bone, but not on the globe. And once they understand that also, you can document stabilization of the process.
Thank you. Thanks a lot. Been a wonderful learning in this session. Thank you.